Hello, y'all, and welcome back to Professor Truelove's Concepts for Nurses series. And in this episode, we will be discussing traumatic brain injuries, the manifestations, and interventions. As usual, our sources will include Iggy's Medical Surgical Nursing 9th edition and Soul's Introduction to Critical Care Nursing 7th edition. Traumatic brain injury occurs as a result of an external force applied to the head and brain, causing disruption of the physiologic stability locally at the point of injury, as well as globally, with elevations in ICP and potentially dramatic changes in blood flow within and to the brain. This may result in diminished or altered states of consciousness, and they may include a sharing injury known as a diffuse axonal injury. The incidence and impact of head injury falls most heavily on the ages 18 to 34 years old, and in that demographic is the leading cause of death from trauma. This results also in a high hospitalization cost and rehabilitation because of the young age and the fact that the rest of the body is healthy and the patient may live for many, many years, especially if there is no lasting damage to heart, lungs, kidneys, and other vital organs. Brain injuries are further divided into primary and secondary injuries and may result from either open or closed head injuries, can be classified as mild, moderate, or severe, and in many cases involves fractures. Leading causes for traumatic brain injury include motor vehicle accidents, falls, assaults, and the combination of injury while being intoxicated on alcohol. Again, a head injury occurs as a result of a blow or jolt to the head, or as a result of penetration to the head by a bullet or other foreign object. As a result, the normal functioning of the brain is disrupted. Regardless of the severity of the injury, the patient may have short-term or long-term physical, cognitive, financial, and emotional consequences. Classifications for brain injury include primary brain injury, which is a direct injury to the brain tissue. As the brain is injured, it can sustain injury to the area under the direct impact, which is known as coup, as well as to the distal site of the impact, or contra-coup injury. This violent movement can lead to concussion, which is essentially temporary injuries from the shaking of the brain within the skull. Contusion, or bruising of the brain, penetrating injuries from bullets or blades, shearing injuries known as diffuse axonal injuries, and the presence of blood or old blood known as a hematoma. All of these can cause the complication of intracranial bleeding. A secondary brain injury occurs as a result of initial trauma and is characterized by cellular changes leading to vasogenic cerebral edema. Acceleration injury is caused by an external force contacting the head, suddenly placing the head in motion. Deceleration injury occurs when the moving head is suddenly stopped or hits a stationary object. Secondary injury occurs after the initial trauma and causes damage to the neurons and is a result of hypoxia, hypotension, fluid and electrolyte imbalance, uncontrolled increased intracranial pressure, and cerebral edema. An open head injury occurs when there is a skull fracture or the skull is pierced by a penetrating object. The integrity of the brain and the dura is violated, and exposure to outside contaminant occurs. In contrast, a closed head injury is a result of blunt trauma, and in this case, the integrity of the skull is not violated. This schematic shows how traumatic brain injury causes ischemia, increased ICP, and a vicious cycle of destruction of the neurons. Review. In an open head injury, the scalp is torn or a fracture extends into the sinuses or the middle ear. In a closed head injury, this is a result of blunt trauma, and in this case, the integrity of the skull is not violated. These are caused by acceleration and deceleration forces. Scalp lacerations are common in traumatic injuries and are often associated with skull fractures. They are defined as a break in the scalp, and they result in a risk for infection. You should remember that the scalp is very vascular, and there can be significant blood loss and difficulty stopping the bleeding. Lacerations may prove dangerous depending on the location of that laceration and the presence of any contaminants. A linear skull fracture is a simple, clean break. The impacted area of the bone bends inward and the area around it bends outward. It is the most common type of skull fracture seen. It is a simple crack on an X-ray. Symptoms may include swollen, ecchymotic areas over the scalp, and the nurse should observe for signs of intracranial bleeding and epidural hematoma. A basilar skull fracture, as the name implies, occurs at the base of the skull. It usually extends into the anterior, middle, or posterior fossa and results in cerebrospinal fluid leakage from the nose or the ears. There is a potential for hemorrhage, damage to cranial nerves 1, 2, 4, and 7 especially, and a risk for infection. A depressed skull fracture is when the bone is pressed inward into the brain tissue to at least the thickness of the skull. This means that broken bones may penetrate meninges or brain tissue. Types include closed with the scalp intact, compound with the scalp open but the dura intact, and complex with the dura lacerated by bone fragments. Symptoms vary depending on the individual and the circumstances behind the injury. However, there is a depressed area in contact of the skull which is palpable. There will be CSF leaking from the nose, ear, and in the postnasal area. There will be scalp bruising, tenderness, laceration, and a palpable depressed area over the skull. Remember that the dura may be intact, bruised, or torn. Complications include laceration of the brain, intracranial hemorrhage, infection, and in most cases, surgical intervention is needed to help the patient survive. In a comminuted skull fracture, this involves fragmentation of the bone with depression of the bone into the brain tissue. It's essentially multiple linear fractures with a depressed area at the site of impact, sort of like an eggshell fracture. This fracture originates and radiates toward the impact site and the base of the skull, and the risks are similar to that of a depressed skull fracture. Management of the patient with traumatic brain injury involves a significant amount of nursing care, including neurological assessment using things such as the Glasgow Coma Scale, maintaining and assessing airway, monitoring for complications of increased intracranial pressure, hemodynamic monitoring, interventions to control the elevated intracranial pressure, and evaluation of diagnostic tests. Management, both nursing and medical, of a patient with a traumatic brain injury mirrors that associated with the patient who has increased intracranial pressure. So the nurse would be prudent to review nursing care of the patient with increased ICP. We will be discussing increased ICP in a subsequent broadcast. For now, realize that there are several surgical procedures that can be applied to this type of patient, including a craniotomy to remove bone fragments, to evacuate any existing hematoma, and to remove any other type of foreign body. That does conclude this episode regarding traumatic brain injury. However, this is not the end of the neurological series. In our next episode, we will discuss cerebral hemorrhage. As always, take care, and we'll see you then.